Hello, my name is Lori Boatwright, President-elect of the Michigan Physical Therapy Association's Oncology Rehabilitation Special Interest Group. And on behalf of the leadership team, I'm delighted to welcome you to this unique learning opportunity centered on global health and cancer programming. Thank you to Emily Cook, our communications chair, for setting up the logistics for this session. And thank you to our speaker, April Gamble, a graduate of Grand Valley State University's Doctor of Physical Therapy program and global health specialist, for providing the content for this presentation. I'd like to provide a brief history on our unique organization, the first and only state-level special interest group dedicated to clinical best practice development and advocacy for cancer survivors. We are now able to expand our impact with the creation of a new position on our leadership team, with April at the helm, to integrate our initiatives on a national and global level. We are pleased to endorse the ACORS project she is developing. She will discuss this project as well as many other concepts related to her work in global health. Welcome, April.
Thank you, Lori. So thank you for everyone for coming together today. The goals of this presentation is to spend about 40 minutes describing global health, sharing some of the key principles of global health, and then sharing some opportunities for you all to get involved in the SIG's Oncology Outreach Committee. So I'll share a little bit about who I am. So as Lori said, my name is April Gamble. I am a native Michigander. I grew up in Cadillac, and I went to Hope College for undergrad, and then I went to PT school at Grand Valley. After Grand Valley, I did the neurological residency at Mary Free Vet in Grand Rapids. That's that picture up here on the left. And then after the residency, I moved to China, where I lived and worked for 2 years, providing pediatric physical therapy services. And then this was also my first real taste into global health. And I developed a very big passion in developing programs and rehabilitation services and helping to enhance rehabilitation services in developing countries. I remember one client I worked with. He was a 12-year-old Chinese boy who had CP, and he was ambulatory, independent, until he was recommended to have a surgery, an orthopedic surgery, to correct a foot deformity. And then after that surgery, the doctor told him to lay in bed for a year. And as you can imagine, he lost his ability to walk and do a lot of his functional independence. And so that's when I saw him, and we worked together for a long time, and he did gain functional independence in walking with assistive devices. But that whole experience really showed me how, we can only, as one physical therapist, we influence people's lives and transform their human experience. But if we can take a broader perspective and look at how do we influence a system, how do we influence programs? How do we influence whole services? And that's really how we can make a more significant impact. So that's how I got interested in global health. And since then, I've worked in Jordan for 2 years, and now I've been in Kurdistan, Iraq for 3 years. And you're going to learn a little bit more about my work as we go along. I am also on the board of the Global Health SIG of the American PT Association. And then I'm also the director of the American Center for Rehabilitation. All right, so let's get into our presentation here. So as you can see, global health is defined as an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So I really like this picture here because it shows how equity and equality are not the same thing. Equality is treating everyone the same, but equity is giving everyone what they need to be successful. So if you think about this through a disability lens, if we have a school for children, equality would mean that we allow all children of all abilities to participate and attend school. But that's not equity. Equity is that we give every child what they need to be successful in school. So does that mean that they need a wheelchair to be able to mobilize themselves around the school? Do they need aides to support them so that, again, they have the same level so that they have what they need to be successful? So when we think about global health, when we think about health equity, that's how we want to see it. So one important thing is to know that global health is not the same thing as international health. This is a very common misperception. So international health focuses on health issues of countries other than one's own, usually low income or middle income. And it kind of has the perspective as us going in and helping them. But global health focuses on issues that directly or indirectly affect health, but it can be local and international. So global health, an example, is many PT universities have pro bono clinics within their community. A pro bono clinic is an excellent example of global health. And global health focuses on working with vulnerable populations. So you can see some of the definitions in the literature about vulnerable populations. But they are groups and communities that are at a higher risk for poor health because of barriers. These barriers could be social, economic, political, environmental, also due to limitations to illness and disability. And so they are any group whose healthcare needs exceed the average, or those who are at greater risk for poor health status or at greater risk for having difficulties accessing healthcare. And of course, we all know there's many vulnerable populations throughout the United States and throughout the world. And if you think of vulnerable populations, there's things that make them vulnerable. There's intrinsic factors like age. So if you're very young or very old, you're more vulnerable. Race or ethnicity, and I'm going to talk about that in specific to cancer care soon. Sexual orientation. There's a lot of research now going out in the States about how the LGBTQ community has difficult time accessing quality healthcare within the States. Also factors like illness, pain, disability, and cancer. And if you think about extrinsic factors, these could be things like war and political unrest, but also natural disasters or cultural and social norms. So what are the cultural norms in their community about cancer screening, for example, or about cancer rehabilitation? Other extrinsic factors are poverty or low socioeconomic status. And all of you, I'm sure, can think of many examples of vulnerable populations in your own community. Let's look at how this inequality applies specifically in cancer care. So you can see the research journal article that I pulled this information from. So first it talked about the uninsured populations. This may be a little outdated, but it was the most recent one we have. But if you look at what it also says is that insurance status alone does not account for the fact that the 5-year cancer survival rates are lower for Blacks than for whites and non-Latinos. That's a pretty significant conclusion. And you can see here what the article concluded about what are the factors contributing to that discrepancy. So decreased access to diagnosis and therapeutic measures, decreased access to clinical trials. As you may know, a lot of clinical trials focus on white, affluent populations. Also, it can be poor expectations regarding the outcome from cancer care or distrust in the healthcare system, which all decreases access to healthcare and a person's utilization of healthcare. Stigmas related to cancer and death, as well as literacy and language barriers. So if we think about it, there is inequality in cancer care in the United States, and of course, that is true around the world. So why am I talking about global health? Why am I talking about vulnerable populations? And the reason is because it's our responsibility as physical therapists. So as you can see, the APTA Code of Ethics states that physical therapists shall participate in efforts to help meet the health needs of people locally, nationally, and globally. So you can see in the first point, this includes pro bono services, but it also includes advocating to reduce health disparities and healthcare inequities around both locally, nationally, and globally. And so it's not only our job as a PT to provide a direct service, but it's also our job to think about how do we advocate for those vulnerable populations? How do we help develop services so they can have access to care? You can also look at a couple other reasons why PTs we should care about this. One is a Convention on the Rights of Persons with Disabilities. So this requires that all countries ensure that people with disabilities are provided with appropriate health services, including habilitation and rehabilitation. And also the WCPT, or World Confederation of Physical Therapy, also states that every individual is entitled to the highest possible standard of culturally appropriate healthcare, where there is trust and respect, as well as clinical reasoning and scientific evidence. So if we think about that, we as physical therapists are responsible for thinking and seeing our work through a global health lens. So that's why I'm here today, to tell you a little bit more about global health and the key principles of global health, and to get you thinking about how you can apply these in your own work, and to show you how I apply them in mine. So I work as a global health physical therapist. I think the best way I've found to describe what I do is coming alongside communities to strengthen rehabilitation services for vulnerable populations. This includes program development, so developing and implementing new rehabilitation services. It includes education and clinical supervision, so actually educating and training physios to provide better clinical care. It includes research. I just completed a randomized controlled trial with Northwestern University to look at a treatment service for survivors of torture in a prison. And then also clinical practice, so providing care in a high quality way that sets an example for what physiotherapy and rehabilitation can be at the highest standard. So a little bit more about my work. So right now I am in the Kurdistan region of Iraq. As you can see there on the map, it's that green area. So this is a semi-autonomous region within Iraq. So they have their own government, but they're still within the greater country of Iraq, and they're not their own country. This is different than maybe what you've heard recently about Kurdistan region. So there's also a term called the Kurdistan region, which is an area of land that the ethnic group, the Kurds, reside in, and that spans Syria, Turkey, Iran, and Iraq. So from right now, when I say Kurdistan, I'm talking about the Kurdistan region of Iraq. And so in Kurdistan, I've been here for over 3 years, and I really work to develop the profession through trainings, developing services, and I'm going to focus today on the cancer rehabilitation services I'm working with. So there's a beautiful picture of part of Kurdistan there. So let's kind of start our journey on what cancer rehabilitation looks like in Kurdistan. So in Kurdistan, oncology care has developed a lot in the past 10 years. And it's really being seen as an emerging cancer hub, which means that people from neighboring countries often travel to Kurdistan for cancer care because it's superior to other countries in the region. And then also, the statistics from the government is that the Ministry of Health reported over 5,000 new cases of cancer within Kurdistan as of 2016. The data here shows that the most common cancer for men in Kurdistan is prostate, which is different, or is prostate in the United States, but here in Kurdistan it's actually different. The most common cancer here is lung cancer. And my assumption is possibly due to the high smoking rates that are here. And then in Kurdistan, as well as the United States, breast cancer is the most common with women, but there is a unique difference in Kurdistan where they have found that women are diagnosed at a younger age here and at a later stage of the cancer compared to research in the United States. So there are 4 cancer hospitals throughout Kurdistan, located in 3 cities. You can see them there, and this is a picture of some of the staff at Hiwa Cancer Hospital. And these serve large populations, so many people that live in villages or small towns need to travel to one of these cities, which could be 2 to 4 hours away, to receive cancer care, because the cancer care is only really located in the large cities, and there's not real treatment services available in smaller towns. So a little bit about the background about the physiotherapy and rehabilitation status in Kurdistan. So most physios are educated with a 2-year degree, so a technical degree, but they are graduating their very first class of the new bachelor's physiotherapy program this year. So as of this year, they will have an ongoing bachelor's program for physical therapy. The curriculum still is fairly heavy in the biomedical model with an emphasis on modalities, but that is shifting with the new bachelor's program. And just as you all know, the struggle of physiotherapy getting recognized in the States, the physiotherapy profession is starting to get recognized more and more in Kurdistan amongst physicians and the healthcare system, but it still needs to go a lot further to really understand the profession and get them integrated into the healthcare system. So we have started the ACORS project, which is a capacity building project to enhance cancer rehabilitation services in Kurdistan. And you're going to see how this came about throughout the presentation. But just some background about this project. It's called the Advancement of Kurdistan Oncology Rehabilitation Services, or ACORS for short. It is actually funded by the Kurdistan government through their cancer fund. So they tax cigarettes, and that tax money is supposed to be used for something related to cancer. But this is the first time that it's ever been used for a capacity building project. It's ever been used for something related to rehab. And this is actually the first time the government's ever funded a capacity building project in any sector, not alone just health. So it's really quite groundbreaking. And this project, ACORS, will go from November now to November 2020. It's going to be throughout all 4 cancer hospitals I described to you. The majority of the activities will be by foreign trainers like myself, and will be mainly for physios. And the goal is to enhance cancer rehabilitation services. So we'll have trainings on these different topics that you see here. And the staff will be expected to demonstrate competency in new clinical skills, both on written test and practical demonstration. But a unique thing is that as the physiotherapy profession is only really a 2-year degree, it's important that we recognize that this training program is teaching them cancer rehabilitation skills, but simultaneously we are giving them the foundational skills it takes to be a PT. So we're going to uptrain at least 40 physiotherapists through this program to not only provide cancer rehabilitation services, but also to provide a higher level of physiotherapy services. This project also includes providing basic equipment so that each hospital has a space for rehabilitation and the appropriate equipment for that. It also involves having a website available for resources in Kurdish and Arabic for cancer survivors and their families. And this part is really exciting to me. There's a lot of, as you all know probably, a lot of misinformation out there about cancer. And just as in the States, people here use Dr. Google to learn about their condition, but there's really not a lot of good quality evidence-based resources available in Kurdish and Arabic for them to turn to. So this website will hopefully be a resource for the entire Middle East region. And then also we will be implementing a group education and exercise class at one of the hospitals. This will start at the person's time of diagnosis, and then will be an ongoing exercise class for all cancer survivors at any stage of their care continuum. So that's a little bit about ACORS. Now what we're going to do is I'm going to describe key principles of global health. As I describe them, I'm going to give you kind of the definition and some key points, and then I'm going to share how that applies to my work in relation to the ACORS project to give you an example of what it looks like. So the first one is appropriate attitude. So an attitude is a settled way of thinking or feeling about something that's typically reflected in a person's behavior. Now our attitudes are shaped by a lot of things. It's by commercials, by what we see on Facebook, on media, possibly our religious background or our family values. And when we do global health work, we really have to be aware of what attitudes do we hold. So one important attitude is that we see strengths and potential in a community and not problems and poverty. So you can think about this the same way in patient care, right? We say, let's be strength focused. So let's ask our patients about what are their strengths and then utilize those to help in their treatment. The same thing is true when you're approaching a community to try, or when you're approaching a system to try to develop a program. You have to see their strengths and potential and not focus on their problems or their poverty. Another appropriate attitude is that we have to move away from thinking we know best to moving towards they know best. I see this a lot when it comes to global health work that's international, where the foreigners come into a community and say, we are the experts, we know what's best for you. But that's not the case, right? They know what's best for them. That population you're working with is living in that situation day in and day out, and they are the experts on their life. They're the experts on what cancer rehabilitation services are going to be accepted by the community, on what systems will work. So taking that attitude is very important. The next one is a savior complex. This term is used a lot throughout the global health literature. Another term they use is white knight syndrome. So it's this idea that we feel the need to save other people. And the idea that I have the answer and you need me to get to the solution. And as you can imagine, this can be very distressing and will not lead to a collaborative outcome with the communities you work with. And then lastly is culturally responsive practice. So you may have heard other similar terms like culturally sensitive or cultural competence, but I really like the term culturally responsive because to me it recognizes that the cultural exchange is 2 ways. Me as a healthcare professional, I have my own culture. my own beliefs, my own values, my own experiences. And I shouldn't deny that I have that. And then people I'm working with also have their own culture, values, and beliefs, and we exchange. So culturally responsive is that I recognize how my culture influences what I do, and I recognize how someone else's culture influences what they do, and that it's an exchange and an openness and a humility to that exchange. So let me give you an example of appropriate attitude. So in one of the hospitals, the cancer hospitals where I was working to help develop a care pathway for this group exercise class, I was meeting with the leadership, and we were talking about the care pathway. So when should the person start the exercise group? So we said, well, it's best to start after diagnosis. So that after the time of diagnosis, they would immediately come to this group where they would learn what is cancer, what's the effects of cancer, and ways that they can stay active and help decrease the negative effects of cancer treatment. But the leadership there said, well, the problem is though, a lot of the patients don't know that they have cancer, because a lot of the families pressure the doctors not to tell the patient that they have cancer. So it's very common for patients to not even be aware of their cancer diagnosis or their prognosis. And as you may be having, you might be having a visceral reaction to that. And I kind of did too, right? Like from my culture, from my values and beliefs, that's not right. You know, the patients need to be informed, it's unethical, and it really triggers that idea that that's not right, and the patient, you're removing the patient's dignity. But if I would have reacted in that setting in that way, that wouldn't have been helpful, right? That would have just created a barrier between me and that hospital and that leadership team. So rather, I just asked questions. In that meeting, I just tried to understand, well, why is that the way it is? What does that look like? You know, and through that, the leadership knew that that wasn't best practice. They knew that that wasn't what was recommended, that it was unethical, but they really struggled with knowing what to do with that. So the leadership there had many conversations, and I just let them have that. I was removed from those, I wasn't part of it. And eventually they came to a conclusion about how they were going to change the culture in their hospital and how they would change the expectations with families and patients so that every single patient would be aware of their diagnosis and prognosis and would be involved in their treatment decision making. And so that's a really good example where, you know, I just took a step back and said, I don't know what's best here. They know what's best, and let them have the space and time to figure that out. And they did. All right, the next global health principle is collaboration with communities. So when I say communities, I mean any group of people that you're working with to develop a rehabilitation service. So that could be a hospital, could be the healthcare staff, it could be the patient population. A community is just a group of people. So when you collaborate with a community, your attitude is everything. And that's what we just talked about, right? But then also really recognizing that you need to invest the time into getting to know that community, especially if you're outside of it, if you're not naturally part of that community. So I put a picture there of me on a hike with some of my staff. And that's because that's me spending time with them, right, in a leisurely way. And that really helps develop trust. I understand the culture more. And then also, as we move forward, there is a relationship and a trust there that everything can be built on. And as we think about collaborating, it's very important that we listen and learn first and do second. Or you can think about it as be a human being and not a human doer. Those are both phrases that are used a lot in global health work. Because you can't just enter a community and just start doing. Because if you do that, you're not doing what's needed. You're not taking the time to understand them, understand the needs, and understand what will work. So just taking the time to exist and to be, and then to see where things evolve. The other important part about collaborating with communities is that being culturally responsive, which we talked about already, and then also being ready for others to not see things your way. Again, that's that appropriate attitude of I'm right, they're wrong, I know what's best, and they don't know what's best. I'm the expert here. So really just being aware of your attitude and how you approach a community. And then it's also very important to know how power dynamics affect everything. In any situation with humans, there's always power dynamics. And especially when you are an outsider to a community, when you have education, when you have credentials after your name, you will be put on a pedestal. Even if you don't want to be, you will be put there, and I experience that regularly. And so just recognizing what that does and recognizing how that influences decisions that are made and actions that are taken by you, but also by other people. So an important part of that collaborating with communities is a collaborative needs assessment and program development. So the needs assessment is maybe a term you're familiar with or not, but it's just the idea of coming together and evaluating what are the needs of the community, and then developing the program together. So it's important during both of these processes that you give every stakeholder or everyone who needs to have a voice, you give them a voice. So you allow cancer survivors to tell you their needs. You allow healthcare staff, from the physicians and the leadership, but all the way down to the assistants and the nurses and the social workers and everyone in between. So you need to make sure you give a platform so everyone has a voice. And in that process, understand your power and use your power to your advantage to say who's coming to the table and who's giving a voice. So let me give you an example through the ACORS project of how I collaborated with communities. So our goal was to enhance cancer rehab services, right? But I did not just come into the healthcare leaders and offices and the hospitals and say, look, you don't have good cancer rehab services, we need to develop this. No, what we did is we first did an introductory course in oncology rehabilitation. So this was a 3-hour course. We did it throughout in every city at each cancer hospital. And we included physical therapists, oncologists, oncology nurses, as well as the hospital leaders or decision makers. And this course was just what is cancer, what's the effects of cancer treatment, and what does cancer rehabilitation look like, and what's the research say about it. We also had a lot of formal and informal discussions with the healthcare staff and cancer survivors. As I said, giving everyone a voice to say what's working well, what do they have, and what do they see the need is. So that's the collaborative needs assessment. And as a result of that needs assessment, which probably took about 6 months to a year, all stakeholders expressed strong interest in enhancing cancer rehab services in Kurdistan. And they recognize that the cancer rehab services are non-existent or severely underutilized. Also, as a result of that needs assessment, we understood why that is. So you can see the factors that contribute to the gap in rehab services. And I bet if you look at that, it's probably pretty similar to why there's a gap in the States as well. So there's a lack of awareness of the evidence-based recommendations, a lack of trained healthcare staff in cancer rehab, a lack of infrastructure, for example, care pathways so physicians can easily refer to rehab, and a lack of awareness in the community of the role of cancer rehabilitation. And then also you can see there that on the other column, that the 3 cities that provide cancer care each have very unique differences. So they have differences in the language. They speak different languages in the different cities, differences in cultural norms and their expectations of healthcare. They have differences in the number of available physios and differences in their access to educational programs. So because of this assessment, we know that we can't just do one-size-fits-all training program. We have to tailor it to the needs of each of these communities because they are different. So as a result of that long needs assessment process, developing relationships, what happened was that actually the leadership of the hospital said, look, we need cancer rehab services. We get it. We understand why this is necessary. And they went to the government and said, give us funding so we can make this happen. And so the leadership in the hospitals really pushed the government to create this funding opportunity. And that's why ACORS happened. And that's a good example of how you collaborate with the community rather than me as an outsider, as a foreigner, pushing, trying to bring money from outside. No, it's just coming alongside them and them giving them the authority and the power to move it forward. All right, the next global health principle is evidence-based practice. So you guys all know what evidence-based practice is, but you can take it and think about it from a global health perspective as well. So you can apply it not just to client care, but also to any time you're developing a program. So you can think about it like the patient values and preferences are also the values and preferences of the community you're working in. Also, when you think about the best research evidence, this of course means literature, but it also means the information you gathered during your needs assessment. It means the culture and the context that this community exists in, and it means the data that you're collecting from your program evaluation, right? What are the needs of the patients, and what are the outcomes of the program that you're doing? And then lastly, you have your clinical expertise, but you also recognize that that's the expertise of the staff you're working with and the patient population. So let me give you an example from the ACORS project of how to apply this evidence-based practice. So we were looking and developing outcome measures. So we would have pre and post data for this group education exercise class. And as you know, the literature recommends to use the NCCN distress thermometer, which is pictured there. So we did that. We decided, okay, let's try this out. We translated it into the native language. And as you probably know, if it's a greater than 4, that means that it's likely that they need a mental health referral, right? So we tried this out, but everyone, all the patients we tried it out with were scoring like 8 or 9 on this thermometer. And when you talk with them, that's clearly not the level of distress, and they clearly were not needing mental health services. So we recognize, this tool is not valid. And it's probably not valid for multiple reasons because, for example, they're not familiar with a thermometer like this. The scoring from 0 to 10 is not something they're familiar with. And also the word distress is really difficult to translate. There's not one concise way to communicate that in Kurdish like there is in English. So we said, okay, that's not going to work here. So what is the literature saying? Well, the literature is saying that you need to consider the mental health needs of cancer survivors and screen for those who need more specialized mental health support. So what we did then is we decided to use these other 2 screening tools, the GAD-2 and PHQ-2. And I had used these screening tools in other settings within Kurdistan, so I knew that they were valid and reliable within this population. So again, we used the translated version and we piloted it and said, yep, this seems to be a valid way of screening for mental health problems and mental health referrals. So that's how we used. So that's just an example how you take the culture and the context in addition to your experience and what the literature says to create a program that's best for the community. All right, the last global health principle is commitment to sustainability. So really, when you're thinking about developing programs, you want to think long-term, not short-term, right? So you want to think, will this program remain after me or my other colleagues who are really championing it after they leave, right? So to do that, you plan for your long-term involvement. 6 months to a year is not going to cut it to get a sustainable rehabilitation service or a new program developed, right? You need to have a longer-term commitment than that. Because right now, for example, it's been 3 years, and now we're just really starting with this cancer rehabilitation project here. You also have to think about the relationships you have and the leadership. So I see a lot of programs fail because there's one leader who has the vision, who has the knowledge and skills, but then when they leave, no one else has those skills and the capacity. So then the whole program suffers. You have to think about your time as well as the resources. Again, if, for example, you are an outside organization funding a pro bono clinic, for example, if that funding ends, are there other resources available? What's the plan for that so that it doesn't just go under because one funding source backed out? So really thinking about that long-term involvement, because you can do a lot more harm than good if you don't plan for the long term. And then ultimately, you also need to think, how are you going to develop a program so that it will continue after your support or the support of your organization ends? So how do you build capacity within an organization so they can continue providing the service? How do they maintain financial resources? How do they maintain equipment? And how do they maintain quality leaders to continue a program after you leave? So for example, here, I've been here for 3 years, and really just now I'm starting to see the fruits of my time here. It just takes time to be with a community and for them to gain trust. And it takes time for them to build the leaders and to get the funding and to get the sustainable roadmap so that it can be a long-term project. And I really see the importance of investing time to build relationships and trust. For example, here, they see a lot of foreigners and a lot of foreign organizations come and go and kind of leave them stranded. Try to develop a program, but then it's no longer sustainable after they leave. And so they kind of have some distrust for organizations at times or for foreigners. And so I saw that I've gained a lot of trust by just being here and for not leaving during times of civil unrest, and for just standing by them as they go through the processes, as they go through the time and effort it takes to get funding and to get support. And then also, as I think about the future, it's important that I think about how do I build up leaders so that when I do stop being involved, there's going to be leaders here on the ground who are passionate and they have the skills to continue the cancer rehabilitation program, and not just continue it, but to continue to develop it, enhance it, and continue it for it to be evidence-based. And how do they also, very important, have the funding, the financial resources to continue a service? So that, again, we don't offer something and then it goes away once the international aid funding is removed. So the Oncology Outreach Committee is endorsing the ACORS project, which I just described to you. So what I want to share with you now is just opportunities that you have to be involved in this cancer rehabilitation project in Kurdistan. So you can see some of the opportunities there, from reviewing training materials to exploring research opportunities if some of you are involved in cancer rehab research, exploring recording video and audio lectures so we can make it available on that website platform that I talked about. So there's lots of different opportunities. So if you're interested in supporting the ACORS project and in supporting the outreach committee of the SIG, you can contact me. There's my email. And I'm in charge and just kind of seeing who's interested and assigning projects that is relevant within your expertise and in the time and that you have to give to it. So please reach out if you have any interest. And now I'll pass it back to Lori so she can tell you a little bit about how to join the SIG if you're not a member.
Thank you so much, April, for enlightening us on those key concepts related to global health, and specifically for us on your initiatives related to cancer program growth and development. We are so proud of you and your work, and really are nothing short of delighted to continue to collaborate and support these efforts. So thank you so much for the opportunity to work with you. If you have interest, we are always looking for driven students and clinicians to be a part of our special interest group. You may reach out to me at my email address, which is on the screen there, bowright@oakland.edu. Really, our mission and vision of the SIG is, as mentioned, to promote clinical best practice development here in the United States, as well as now with April's involvement now globally. Certainly these are needed not only in third world countries, but also here in the United States. There is definitely work to be done. So this effort in partnering with April is certainly collaborative in nature, and one of the reasons why it was so attractive to both she and our group to collaborate and work together on these efforts. So you may reach out to me at any time and I will connect you with various leaders. Our leadership team is very diverse in skill as well as interest in promoting these initiatives. So it's not always me who's going to be the point person, but certainly our, again, dynamic board, very active in research, very active in education, disseminating all of this information both to the entry-level student as well as advanced practitioners. And now with this global health and stateside initiative for outreach, we have opportunities for you to connect and engage there as well. So thank you very much for your time. I would like to open it up for questions.
Yeah, and I think you can just write in the chat box there if you have any questions, and we can read them out. I'll just refer back here. You do have some key references here about the global health if you're wanting to learn more about that.
In the absence of questions or comments at this time, those certainly can be filtered through. Oh, I do see one.
Oh yeah, so Deb is asking, why do you think that breast cancer is diagnosed earlier? So Here, yeah, so as I said, in Kurdistan, the research shows that it's diagnosed at a younger age at a higher stage. And I haven't seen a lot of research about exactly why that is. Obviously, the data collection here is kind of in the preliminary phase. My assumption would be that there's probably a genetic component. But again, I haven't seen any data about that. So I'd be curious if anyone has any research and about the genetic component and the genetics and regarding breast cancer and Middle East genes. And then also possibly environmental factors, exposure to pollutants, chemical warfare, and other things like that might be contributing to that. But again, that's just my thoughts, but I'm not sure exactly.
Any other questions or comments for April at this time?
Oh, here we go. How were you able to convince the physicians about the importance of exercise? Good question. So I think one of the biggest ones was that introductory to oncology rehabilitation course and really just presenting the evidence. People here, and I think this is probably true everywhere in the world, they want to do best practice, right? They want to do high quality clinical work. And there's different reasons why people can't do that, right? And one of them is just a lack of knowledge. So presenting that knowledge to them was one of the very first steps. And I was really happy with physicians, bought into it and completely understand it. But now, what's really needed is now working with them to create that infrastructure, those care pathways, training the staff to now be able to make that a reality and to really develop the cancer rehab services now that we have the physicians on board. There's another question here. So neuropathy, fatigue, and cardiotoxicity are major adverse effects here in the US. What are the most common adverse effects there? Nice. So during the needs assessment, when asking survivors and staff, one of the biggest ones is lymphedema, specifically arm lymphedema post-breast cancer. So I think one of the reasons that that's the most reported is because it's the most visible, right? So patients notice it, doctors notice it. I don't think many physicians and many healthcare staff are asking patients about neuropathy. I don't think many are asking about fatigue or cardiotoxicity based on my conversations with people. So I think those are major adverse effects that are obviously here too, but they are not being asked. And that's part of what we're going to do is start just raising awareness that those are adverse effects and to start raising awareness at all levels of the healthcare system about that. And then the other question, do PTs need a physician referral? So here, no, they do not need a physician referral. So I guess it's direct access, but it definitely supports the rehabilitation process if a physician makes that referral, because then the patient sees it more because they see the physician as the authority. They see it more as something that they must do. That's very important. They trust the doctor's recommendation in that. So the patient comes in with some positive beliefs about the importance of physio and rehab if the physician helps make that. So it is an important process that we need to look at, is that referral process. All right, I think there's no more questions. Lori, do you have anything?
I do not have any questions at this time. I extend our continued gratitude for your efforts abroad and now for your desire and willingness to collaborate with us to help grow our programs here in the United States as well. Thank you so very much.
Yeah, thank you everyone. And I'm very excited to be part of the SIG and to look forward to all the work that we do together. So thank you.
Wonderful.